Do we have our presenter here this morning? Do we have our presenter with us this morning yet?
That's me. This is me. I'm just trying to get my share. Yes.
Okay,
Start sharing. I just don't see my slides yet on the screen.
okay. Next to the microphone button, there's a picture of a computer monitor. Go ahead and click
Okay, that's
that.
what I did. It tells me that I'm sharing. It says me. It tells me I'm sharing. I just don't see. Okay, let me start again. Oh, I've done it before, so okay. Share screen. PowerPoint. I just don't see my slides on the screen.
Let me.
But it says
It.
it says I'm sharing
I see your.
PowerPoint.
We see your screen. You're sharing a blank screen, though. You're not sharing the screen that has
Correct.
your slides on.
That's what I'm trying to.
Okay.
Uh, Let me try again. Not sure why it's not. Give me a second.
Okay.
I've, I've done it 100 times. Again. Okay. Okay.
There.
Do you see?
Okay, we're seeing slides now. You want to go ahead
Yeah.
and click Start Slideshow.
Correct. Correct. Let me start. Okay. Okay. I see it now. I'm not sure what was happening.
It
Okay.
it looks good and you sound good.
So we still have a few minutes, I guess.
Yeah, I just wanted to make sure that your audio was coming through and you had your slides up. So it looks like we're good to go.
So I'll give it a few more minutes, or is everybody just checking how many people are in?
You currently have 16 people on the call.
Okay. I guess we can get started. Good morning, everybody. Again, you cannot really get rid of me. Here I'm again. So last time, well, a month ago, so I talked about management of spasticity as a sort of as a specific syndrome, and so today we'll be talking about very specific cause of spasticity. Really reviewing clinical and genetic data. This has been actually interest of mine for quite some time. And so we'll be talking about hereditary spastic paraplegia, or perhaps I should say paraplegias. But let me start. Hold on. I'm trying to advance my slides. Okay. So let me start with the sort of a common clinical scenario when the patient presents with insidious gradual onset of gait difficulties, and on examination you really find just signs of spasticity, but clinical signs of spasticity, some degree of weakness, which always, as I said before, spasticity is a double-edged sword. That it would sort of improve weakness, but of course can be, in a way, if it's dynamic spasticity, as we reviewed about a month ago. So you would have a typical hyperreflexia, plantar, extensive plantar response, and the sensory examination is typically normal. I didn't mention, of course, vibration sensation, which is important for dorsal columns, but a typical modality, spin prick, light touch, temperature sensation are intact. So you can really think about it as a symptoms, quote unquote, below the waist. So this is quite broad syndrome of progressive, again, obviously because it was insidious gradual also with the progression. So syndrome of progressive spastic paraparesis. I have trouble getting slides down, sorry. Okay. So really, when you look at it, as always, even though we are in the field of neurodegeneration, the first thing is the treatable condition. And I'm not necessarily referring treatment of symptoms, but overall treatment, and I will kind of go through some possibilities. Of course, this is a etiology. Would it be really inherited or hereditary spastic paraplegia? Sometimes called familial spastic paraplegia, FSP, even though HSP has been used. Actually, I also need to say that we talk about paraplegia, even though it's paraparesis, and I know that some neurologists I kind of wear two hats, also geneticists, so sometimes neurologists would make fun of geneticists who actually describe this, and they wouldn't recognize a difference between paraplegia and paraparesis. So a paraplegia is actually official nomenclature, even though it's kind of incorrect to be paraparesis, but it's just, so just kind of really trying to be really very picky, but acknowledging that it's not complete plegia, but it's mostly paresis. Now, of course, so is it something apparently sporadic condition? We'll talk about genetics in a few minutes. And of course, and there are some, so potentially is it, primary lateral sclerosis, which is basically type ALS or typical motor neuron disease, because again, if you recall at the beginning, we established that the sensory examination, we didn't talk much about vibration yet, was quote unquote normal. So, and of course, obviously I'm not going to quiz you because you know the title of the talk, but I thought that, following this clinical scenario would be nice to go through. It's not completely, it's not, it's not complete, but it's quite comprehensive. And so obviously structural cord abnormalities, spinal cord compression is always, first thing to consider. I've seen a long time ago patient from a family of HSP, another patient who had also same phenotype as other family members, but this particular person had a meningioma at I think T5 levels, T5 level. So this is what we call phenocopy. So that can be, quite nightmarish situation because you think you're dealing with a familial history, and other patients had a basically familial disease, but you can have also spinal compression. So it can help you if there's a sensory level. Of course, imaging is now quite straightforward, and so obviously these patients need to be imaged to exclude compression. But of course, sensory level, if present radiculopathy, at the level of compression or lesion, I should say, can be helpful. Of course, multiple sclerosis has a very plethoric presentation, pleomorphic presentation. But you can have basically, especially primary progressive multiple sclerosis, you may have basically mostly paraparesis, and of course there would be imaging. You would also see typical white matter lesions, CSF analysis. Potentials are probably done much less so than before, but those are basically, again, but properly imaging and plus minus CSF analysis would be very helpful. ALS will be coming up a few times, and primary lateral sclerosis, which actually has been primary lateral sclerosis has been essentially reclassified as a really subtype of ALS, but it's really the presence of upper and lower motor neuron disease. So far, we have, what I've reviewed would be attributable only to the upper motor neuron lesion. Going down the list, some metabolic conditions, copper. Copper has been kind of very important micronutrient. Actually, I did a lot of work in copper deficiency. I mean, because obviously there's a copper toxicity, but there's copper toxicity, there's a Wilson disease, but there's a copper deficiency, sometimes called human swayback disease, where there's a very progressive myelopathy, but has a very quite prominent also sensory symptoms. Actually, proprioception is completely gone, so these patients are basically so disabled. Tabes dorsalis, of course, is kind of a matter of past, but vitamin B12, vitamin E, but of course you would have a quite prominent dorsal column involvement, plus and other signs of vitamin E could give you retinitis pigmentosa and other retinal degeneration. Again, leukodystrophy sometimes can present. Krabbe's disease has been described. Metachromatic leukodystrophy sometimes can present as a really, especially adult onset. So obviously, we had a great talk about leukodystrophies, I think about a year ago, maybe even less so, from somebody from Cleveland Clinic. I forgot the name, I apologize. But so some of these late onset adult types, may have less typical, really kind of myelopathy presentation. Spastic ataxias, you would say it's very easy to distinguish spastic paraplegia, and there's actually a condition of ataxias called spastic ataxias, which I won't talk much about today, which actually would be really, would deserve actually a topic of its own. I'm not trying to volunteer, actually. I feel like I'm getting granadas every month here, not complaining. But what they are looking for the other signs of cerebellar dysfunction. We will talk about it later on. And sometimes these boundaries are blurry. Actually, I remember a long time ago, I had an editorial in one of the neurological journals, saying it's not as simple. For instance, muscular disease or SCA3 sometimes can really present as a seemingly spastic paraplegia. Friedreich's ataxia, which of course we all think about as a ataxic disorder, does there are sort of few families with phenotype is absolutely undistinguishable from HSP. Even though we have all these hallmarks of Friedreich's ataxia, so it can be pretty blurry, and for genetic testing can help you. Last but not least, infectious HTLV1. I've seen very few cases. We always look for HTLV1. Of course, HIV used to be HTLV3. That's old nomenclature because HIV. I've seen quite a few patients in Africa, vascular myelopathy, in Zambia, where I used to go before COVID. Feels like a different life. It's quite common. So, we still would, so this is very broad differential, but again, of course, but many times you do exclude this long list of symptoms. Again, imaging, some basic biochemistry, I didn't mention very long chain fatty acids for adrenomyelonic dystrophy. So these are things to consider. But again, what we'll be talking about would be something what you will be left with when you really rule out this essentially treatable or other conditions to consider. So what is HSP or HSPs? Because again, this definitely should be proved. So it's a group of disorders, again, characterized by spastic, as I outlined last 10 minutes or so. The main clinical features include lower extremities weakness and spasticity. Again, weakness does vary. It's mostly spasticity, but you can have some distal, especially distal weakness. Again, it's very insidious. More or less, you would have a symmetrical, even though we can see asymmetric. I mean, seeing patients with the monoparesis, but that's, of course, you have to be much more alerted to the possibility of structural changes. But it's interesting. There's debate: is it symmetrical? But it's more or less symmetrical. That's a better way to put it. Even though patient would tell you my left leg has always been worse, and vice versa. And of course, it varies so much. There is a really quite broad spectrum, both intra and interfamiliar variability. So typically, again, we have some colleagues from our pediatric division, so over CP and all these patients actually will talk about misdiagnosis of cerebral palsy or perinatal injury. So the history is normal. Perinatal history, Apgar scores are normal. There is normal development, even though some patients may have an infantile onset, so they would never have a quote-unquote normal gait. They would have a tiptoeing from the beginning, but the progression, which sometimes can be difficult to detect, so obviously it's so many times these things I talk quite straightforward, should be progressive, but again, sometimes to detect progression, and is it the growth of the child, for instance, so it can be difficult. But early symptoms typically would include sort of stumbling, you pick up your feet, their mom would tell the kids, and again, and scissoring gait, which is quite obvious. Later on, of course, the symptoms of bladder dysfunction, which I find quite useful, autonomic dysfunction, and some paresthesias, even though, as I said, your formal diagnosis, your formal examination of the sensory system will be unremarkable, but especially may report some sort of paresthesias, even though you may not detect anything but maybe reduced vibration sensation. So classification of HSP can be done at different levels. The first one is genetics, and it's the mode of inheritance, dominant, recessive, and X-linked. There are some mitochondrial types, even though they are not typically considered typical HSPs. There are a few mitochondrial genes which are basically, not in part of mitochondrial genome. We will talk about SPG7, towards the end of the talk. Of course, X-linked recessive, of course, that would be, means that also a female can sometimes be carriers. So this is not X-linked dominant, which would be typically lethal in males. Clinical picture can be diagnosed, can be classified or categorized as a uncomplicated, I kind of sometimes used to call it pure. It doesn't mean the other one is dirty, but it's a complicated or complex, but I'll explain in a minute. So, but uncomplicated or pure HSP sometimes. And again, that basically means, quote unquote, just symptoms below the waist of the spastic paraparesis of variable degree and nothing else. So again, uncomplicated or sometimes called pure would be sort of really limited to the really descending tracts and ascending dorsal columns. So we would have, again, progressive, usually severe low extremity spasticity, variable weakness, typically mild. So weakness, if the weakness is very severe, that would be one of the red flags that this may not be HSP, but some other motor neuron disease. Upper extremities are typically unaffected, yet if you do a thorough examination, you may see brisk reflexes, but there is no loss of dexterity. There are no symptoms. You can even have a Hoffman plus minus positive, but these patients are sort of brisk, but much lower, much more so in the legs. And so you may classify DTRs in the upper extremities as a 3, but there is absolutely no clinical correlate with what I mean by there is no loss of dexterity or weakness in the upper extremities. Or if it's there again, it's another sort of red flag. That's something else. I mentioned vibration sensations a few times. That's something to look for. So we all should have a tuning fork in our pockets or bags or whatever we carry. And so that's something this would be attributed to dorsal columns, but you don't have you have to read no abnormalities of the positional sensation. These patients are not much having sensory ataxia. I mentioned conditions like vitamin E deficiency, whether from malabsorption as a Basen-Kurzweil syndrome or really alpha-tocopherol mutation, which is typical recessive disorder, where you would have a profound, or B12, which is kind of mostly acquired, of course. You would have a very profound dorsal dysfunction with abnormalities of positional sensation. So these patients have, again, syndrome of sensory ataxia. So these patients do not, but their vibration sensation will be slightly impaired. Less commonly, it's interesting now. You think maybe I'm kind of contradicting myself. Sometimes can be dysarthria, minimal dysarthria. Again, yet I said a minute ago, it's a symptom. Symptoms are mostly quote unquote below the waist. Yet, of course, speech is very much about the waist. But we talked about this. Even though this pure and complicated or uncomplicated, these boundaries are never as clear-cut, black and white. But there is definitely some transitional sort of phenotypes. You can have a minimal terminal dysmetria because don't forget about spinocerebellar tracts. So actually we talk about so far descending corticospinal tracts and ascending dorsal columns, but we also have ascending, spinocerebellar tracts. So sometimes you may have a minimal dysmetria, and sometimes can be really head scratcher. Is this a spastic ataxia? Is it HSP? And many times genetic will sort of bail you out. So even though I'm still I'm not that old, but I'm still I still had training before imaging really broke out. So, that's kind of dates you, even though really things have changed, tremendously the last 20 years or 25 years. So I'm not hopefully don't want to sound like dinosaur. But the examination is still really the key. So you cannot, of course, so you still shouldn't get away from a good, thorough clinical examination. But anyway, I digressed. To make the story more convoluted or to flatten, to thicken the plot, actually some of these patients may have a minimal cognitive decline or dementia, especially SPG4. So again, what I'm sort of basically describe as a pure and complicated, almost like would fall apart as a house of cards, which is not entirely the case. Again, there are some blurred boundaries, so don't think about. But it's good to have some concepts in your mind for the especially if you are not really I guess experts or so well versed in HSPs, to really have some concepts. And again, this also can come up on your boards, and so that this framework of reference would be hopefully helpful. So complicated would be when you have additional symptoms, and that basically this is a laundry list of anything, from optic neuropathy, retinitis pigmentosa, deafness. You can read the list yourself. Again, you see amyotrophy. Again, so amyotrophy. Am I talking about lower motor neuron disease? Am I talking about ALS? What is he talking about? He kind of completely blurs the boundaries, not trying to refer to myself in the third person, but so again, you may have so we have to be really, but you can have you may have some amyotrophy as well, and yet this is not ALS, which of course is not a part of, we'll be talking about more differential diagnosis, but you can have some distal amyotrophy, especially in the hands, sometimes called Silver and Troyer syndromes. Ichthyosis, there is a one condition, Larsen syndrome, which is also very typical. I've never seen a case in my life, and it is I've never recognized. But it's fair to be, it should be said that typically, not exclusively, but typically, complicated phenotype is really seen in more recessive disorders. Again, we talk about dominant, and so this is more seen in the recessive disorders. So again, diagnostic process can be done going through the sort of definitive affected. Again, basically when you have a really progressive gait abnormality and frank unequivocal spinal cord deficit or lesion, then probably affected. Some of these patients are asymptomatic. I've done a lot of work in genetics when I was a fellow, a resident actually, and fellow at University of Michigan. Even as a resident, I seemed to be that every family was living in Iowa. So I spent, in the middle of Iowa, towns, places where 350 people lived. There were a lot of big families, and some of these patients would be clearly spastic, or, they would, But this is our walk. They said, well, I had no problem, but I asked them to walk through it was in the kitchen, seeing these patients, many times in their houses and draw blood. And like they have spastic gait, but, I'm just, this is my gait. This has been like, I kind of want to be quarterback for local high school, but didn't work out because I couldn't run. And, and they almost like don't recognize the disease. It's not anagnosia per se, or denial. It's just, they just kind of really, they are kind of, it's, obviously we would think that this is something obvious, but it may not be. And of course, there would be some sort of possibly affected when you have some hyperreflexia, and a lot of patients may have a hyperreflexia, the medications, SSRIs are done, commonly used, can give you hyperreflexia, but it's not, but, really probable and definitely affected would be criteria of unequivocal spinal cord dysfunction with a corticospinal tract lesion. Or lesions, or not lesions, but signs attributed to the spinal cord and corticospinal tract dysfunction. So I already talked. I want to spend more time about again PLS and ALS, motor neuron disease. Again, PLS has been, which also is a interest of mine, where you have basically diffuse spasticity. So you have a lot of pseudobulbar symptoms. So we can careful distinguishing bulbar and pseudobulbar. I can be very picky about it. And again, we are just talking upper versus lower motor neuron disease. I'm not sure whether Dr. Brown is on call. I don't see the participants, but of course, so you have to be very careful. Is it pseudobulbar? Jaw jerk. Again, I'm not sure how often do you do jaw jerk, but it can be very useful if you have a hyperreflexia, if you have a doubt. Dysarthria, dysphagia would be, of course, variable degree in ALS, but in PLS, these patients are very disabled. And of course, EMG would be critical. So EMG would be normal in both HSP and PLS. So PLS is quote unquote only upper motor neuron lesion. Again, actually PLS criteria require normal EMG without denervation for 5 years. Of course, ALS would be, hallmark would be L-scoria criteria. Would be, obviously, denervation of more than 3 segments and progression. So this is basically, and also, of course, ALS can be genetics, but PLS we think is mostly sporadic cases, and there are few cases described as a potential, suggesting recessive inheritance. Again, it can make sense because, again, as I said, PLS has been reclassified as a potential subtype of ALS, even though I still was preferring a different disease, different to ALS, but again, it's now reclassified as a type of ALS. Pathology is very unremarkable, so it's really, so when you think about adult or any kind of person upright, so if you think about from the top of your head to your toes, these axons are quite long. Depends how tall one is, of course, but it's really the distal. So it's really axonopathy, and I don't have much slides. I did a lot of lab work in my lab of modeling axonal transport. We'll talk about some kinesins soon, but it's really the distal. And again, when you think about it, lower extremities are longest, arms are shorter, so it's almost like length-dependent axonopathy. Similar thing would be, of course, some metabolic polyneuropathies, diabetes, or alcohol, or thyroid, and any kind of garden variety of metabolic polyneuropathy, which is also distal, so it's same phenomenon of the vulnerability, which is length dependent. There is no evidence of primary demyelinization, even though, of course, think about think MS, especially primary progressive multiple sclerosis. But you can have some sort of a secondary with advanced axonal degeneration. I mentioned that some patients have a dementia in SPG4. The substrate is still unknown. There has been some case report of hippocampal pyramidal neurons, loss of those, but again, we don't have a good structural sort of explanation for that. But again, you can think about it as this distal axonopathies, which are basically, again, it's really traffic jam. If you think about, I don't have much, I decided to make it clinical rather than basic science talk, which would be great topics on its own, but it's really like traffic jam. If you think about scaffolding of microtubules in axons. It's just absolutely fascinating. It's such a complicated cellular biology, and it's really difficult to really make any difference therapeutically. So there are some. These are quite old slides. I think those old slides, but again, it's really there is not much written about this, and so again, it's this longest distal extremes of the longest CNS axon. So basically, again, this is extremely old slide, but I don't have a better slide. So it's again these corticospinal tracts, and of course you can think about the length of them in somebody's like I don't know 6'2" or so. So those are pretty long axons. So epidemiology, what are we talking about? Are we talking zebras? Are we talking unicorns? Are we talking thoroughbred horse? Even though, as I said, I already said it in Kentucky, thoroughbred horse analogy doesn't work because every horse is thoroughbred here. But I used to, but we, think of, again, outside Kentucky, this would be thoroughbred horse. Again, this analogy kind of falls apart here in Louisville and horse country. But what I'm trying to say, this is not, you will see this, this is not something you will see once in your lifetime. No, I don't think you will see it every day or every week unless you have a specific interest. But so basically, if you look at the numbers, it's quite variable numbers, from some mostly European studies. The lowest one is actually in Ireland, and highest in Spain, which I think Spanish numbers 10 per close to 10 per 100,000 or 1 in 10,000 is probably, I think, more realistic, which is not that uncommon. And if you look at also, studies from Ireland, 30% patients were asymptomatic, essentially anywhere. So this was a door-to-door survey, which is, a lot of undertaking done in the Cork county. So again, as I mentioned, my travels exciting travels in wintertime Iowa was similar experience. These patients many times have a spastic paraplegias and, nothing wrong with me. And again, I don't think it's denial per se, we can argue about it, but so you have to examine these patients. So many times when you see a child or a young adult, and is there a family history? No. So if both parents come, I always examine them, and, many times, we cannot, tap on somebody's knee and like the knee goes, you get kicked in your face because it's so hyperreflexive, even though, there is no family history. But again, 25% patients or so, quarter have no genuine family history, so they're apparently sporadic cases. And again, I'm trying to think, I think I gave a talk about basically genetics, I know. So one thing can be, undisclosed, adoption, can be false paternity, but can be more sort of prosaic reasons such as de novo mutations. As I already mentioned, genetics, all three groups, again, we don't have a typical mitochondrial syndromes, which I would consider HSP at this point, even though, there are a few phenotypes which could resemble HSP. Really, about 80% or 75%, or 3/4 or so would be dominant disease. Again, 25% would have no family history, but it's still a dominant genes. Dominant mean different things. It can be on different level of cellular level of genetics, but here basically implies it's a 50-50 chance of inheriting for offspring. So many times, you have a patient, patient who is a proband, and then, his or her children may have a disease because they have a 50% chance of inheriting abnormal gene. Actually, mutation. Actually, we are not supposed to say mutation. Pathogenic variants. Mutation is out. Nobody's a mutant anymore, only in Hollywood movies. So now we have a pathogenic variants of DNA. Mutations are politically incorrect, as I was told, and the rest would be mostly. Well, this is official nomenclature. So again, that's the same mutation, but it again pathogenic variants, and the rest would be mostly recessive. X-links are quite rare. Most of my patients actually with X-linked used to be from Kentucky when I was working in Nashville. But the recessive, and again, recessive is also common. Don't think about this inbred families, not necessarily. And so that some of these have a relatively common carrier frequency. So you don't necessarily need to have a consanguinity in the family have a child with recessive conditions. Which mostly would be again our colleagues in Norton, but again, you can also see this once they reach the age of adulthood. So these are basically SPY charts, and again, they need to be updated, even though so. But if you think about this kind of baby blue, if I'm not mistaken, naming the color is actually SPG4, which is spastic mutation, and then we'll go through. So there are a few common types, even though it's very difficult to distinguish. But you have also a lot of still unknown, and I still have a patient. I don't have I did exome sequencing and nothing comes up. So, so it still could be internal mutation. So it's still, with a new, we had an excellent talk about genetics and sequencing, a few weeks ago. And so, new generation sequencing may reduce even genome sequencing, but still have patients who really don't have an answer. So these are very busy. We don't have to go through every number, but those are very busy pies, so there is a lot of heterogeneity, so that's but there are a few, and for sporadic cases, of course, if you look at the sporadic, the lower part, most of them would be unknown as expected. So when I had a few sort of, I guess, paper or chapter in a continuum, which I don't necessarily like to write, even though it's hard to turn down because it's, so, but anyway, so I came up with this kind of thinking about different categorization when I was, writing my first. I kind of really recycled that since, and it kind of really caught on a bit. So when I think about, so age of onset is also a very important part. And again, basically it varies from infantile onset to 80s, so it's, doesn't really help you, but you can cluster these patients, and typically, early age of onset, we typically would say less than 10 years. Of course, they can be juvenile, but the one thing to look at it would be autosomal dominant HSP with early age of onset and uncomplicated phenotype. And so again, would be mostly below younger than 10 years. And most of these patients have a clastin or SPG3A mutation, which is basically the most common type. They are progressive, but sometimes they are not very progressive. So, we've seen quite a few patients misdiagnosed as this sort of now famous or infamous CP, cerebral palsy, which is obviously, again, such a difficult term, outside the, periventricular injury, in my opinion. But again, so it can be but again, SPG3, clastin, and these patients are relatively milder. Milder in a sense of that there's a very few patients who are wheelchair dependent. So it's progressive, but excuse me. So I was actually in the lab. We discovered the clastin mutation. Of course, we couldn't find it. So at last we found it. Even though we made up story for Nature Genetics, that when the editors asked us how we did come up with the clastin name, so we said, the Atlas, Greek mythology, holding the Atlas, a giant holding the Earth, so it's kind of supporting exons. But of course, was finally at last we found it because we were just so frustrated. So the clastin one, it's actually very fascinating cellular biology, which I won't touch today upon that. But really talking to ER shape and Golgi shape. So really ER, endoplasmic reticulum shaping, the cellular biology is phenomenally exciting and phenomenally complex. But again, this is not the subject of today's talk. So again, SPG3, so gene is on, long arm chromosome 14. You have to remember that again. Typically, age of onset would be, even like early. Again, a lot of them are misdiagnosed as cerebral palsy. And again, it's a GTPase, gene is GTPase called again. Actually, it's SPG3A because there was a SPG3B. So they are basically numbered. So SP is a spastic gait. That's a genetic nomenclature. And number was just discovered as they were linked, so there was old linkage. That's how I started my career in genetics. We were doing a I was doing linkage, which is like going to factory, running the gels, things that are automated now. It's not that long ago. And, so run these gels and, with the radioactively labeled, which is like running small Chernobyl in a lab. And but linkage, you could find the markers and microsatellite markers, again, almost obsolete stuff now or hardly ever used. But anyway, so there was number 3 was the third type linked, and it was first linked to chromosome, along arm chromosome 14, and then the gene was discovered. So, but again, if you think about, so early onset disease, when did your symptoms start? When did they start? I was about 5 years old. So think about SPG3A or plastid-based disease. However, if you have a more complicated phenotype, think about SPG10, which basically was the 10th, type discovered, and it's actually one of the kinesin heavy chain 5A. So kinesin, a lot of kinesin, this is 5A, and so this is probably the most common of subgroups, and they have a very significant clear-cut axonal neuropathy with a more distal weakness and maybe amyotrophy. So early age of onset, but polyneuropathy, again, you should have a genetic confirmation, but it works 90%, so if you have this, again, there are cases with the atlastin mutations and severe polyneuropathy, so you have exceptions to the rule. So genotype really is the actual final answer, if you will, but you can still, I think that this phenotypic classification is still very exciting, and that's basically what we do as a clinical neurologists. So you can really, and again, 80-90% time you are correct. Does it change the management at this point? Absolutely not, but it's really the matter of time, I believe. You will have and these therapies will need to be, I think, genetically based. So it would be very unlikely to have a sort of therapy which would be maybe kind of final common downstream. So I suspect that it will be much more. So it will be important to know genetic type of these conditions. Anyway, so this is SPG10, and also some can be complicated by deafness, retinal pigmentosa. Again, go into this complicated phenotype. Sometimes, intellectual disability. This is kind of older slide, so mental retardation should be changed to intellectual disability, and even Parkinsonism. Actually, interestingly enough, some variants in kinesin 5A are very highly associated as a risk factor for ALS. So really, even though I'm trying to make a case how separate these conditions are, sometimes they can really overlap. And so again, it's fascinating interplay of gene, genetics, environment, and clinical presentation. Going to adult onset. So this was basically, again, I typically would say less than 10 years, even though the patients may have like age of onset 5, but 10 years, it's very arbitrary cutoff. It's not a hard stop, but typical adult would be, from, early adulthood to 80s. Again, it's a huge overlap. Again, both intra and interfamiliar variability. So, even within the same family. So these modifying genes obviously play a bigger role if somebody has a severe disease versus relatively hardly any disease. And this is, there is not much reliable differentiation among this type of HSP, so looking at the time. But there are a few clues. But so this condition would be very difficult to distinguish clinically. I think there are no good clues, but there are few. You may have a sort of a luck of draw, because there are a few very common types. Again, SPG4 would be most common. So, statistics would be in your favor, but of course doesn't mean that, it's just really statistics. If there are no good clinical clues to help you to navigate this group of adult onset uncomplicated HSP. Again, most of the, sometimes, these panels, we're kind of moving away from panels, even though, they're still useful. So, this is still, and again, Athena panel, we kind of don't use Athena anymore, much more, but some of these Invita, for instance, is my favorite company nowadays. They have a 50+ genes, But they do it sort of sequentially. So again, you look, common one would be SPG4, SPG6, NIPA1, SPG8. Actually, I was the one who discovered the linkage, and Strumpelin then was identified. And SPG31, REAP1 are really the most common types. Again, it's very difficult to distinguish them. SPG4 may have a subtle dementia. It's mostly mild, subcortical, so subtle. But if you do thorough, like MOCA, you would find signs of frontal lobe dysfunction, even though it's not sort of thought as a dementing disorder. But obviously, these axons are not only, I talk about length-dependent axonopathy, but of course you will have it also obviously cortical or subcortical dysfunction. So again, this is a systemic disorder, even though you have only spastic paraplegia. So SPG4 again is linked, short arm chromosome 2. Accounts probably for about 30-40% of all HSPs. Camille Hazan, it was actually discovered of the gene which is called spastin, and it can be so most patients have a missense, nonsense, splice site mutations, deletions, insertions. So it's really very variable. So you need to really sequence the gene. There are no sort of hotspots there, and really there is no really phenotype-genotype correlation. I mean, there are a few papers trying to make some claims, difference between splice sites, which are kind of mild phenotype versus nonsense, but again, it's not very strong, so I think it's fair to say that there is not much strong established genotype-phenotype correlation. Again, it varies from age of 2, actually I shouldn't say age 2, because I actually described family which infantile onset, so actually, I mean, more, there are a few families, actually one of them was described in my lab, was new mutation of SPG4, and there was infantile onset. So, but most of it I would say 2 to 80, but again, infantile onset is also, which is rare, but again, exception to the rule. Severity varies, it's really, again, even within the families. And again, I think dementia may be more common than previously thought. And again, many times we don't give a very, MOCA to these patients on a routine basis, but I think that, we need to do so. Again, this kind of subcortical type, sometimes seen in Parkinson's disease or Huntington's disease, even though much, much more milder. So, nothing close to dementing disorders such as Parkinson's disease, or of course, Huntington's disease would be quite different in terms of severity, but the patterns can be similar. This is from my paper. So this is actually SPG6, and if you look at this, so actually look at the, I'm not sure you can see my mouse, and so this, basically this is the, if you look at the axial, so this is the spinal cord is gone. There's really no, I mean, so this is I think T12 level, T10 level, if I remember. Yeah, we're doing T10 level in our paper, and so we're like looking at the degree of volumetric studies, and so SPG6, and this is quite progressive. This is very aggressive type. Everybody I've seen in SPG6 was in a wheelchair, and basically see the atrophy of spinal cord is absolutely staggering. I mean, this is the most when we saw this first time, we didn't believe our eyes, because we were also discovering SPG6, the big family we had a big family from Arkansas, and everybody was really very severely affected. Again, below the waist, but they were like in a wheelchair. They couldn't even have weight bearing, and again, spinal cord is basically gone. Again, so if you do imaging and see spinal cord atrophy, but of course doesn't mean it's SPG6, but something to think about. And of course, then doing autosomal dominant disease with a complicated phenotype. But there is a very important condition called Silver syndrome, when there is a prominent amyotrophy of distal hand and foot muscles, high arches. It may be easily confused with the motor neuron disease, but you don't have a paraspinal denervation. So if you ask for EMG, you wouldn't see paraspinal muscles. And actually, this is the picture of my patient's hand. Hopefully it does so, but if you're not sure, it's kind of gives it justice, but the thenar and hypothenars are gone, the hand is flat, and so it's also atrophy, so it's very atrophic, it's a weakness, thumb is weak, most of them are really SPG17, even though Silver syndrome can be seen also in the SPG4, SPG3, I'm just working on a paper, REAP1, SPG31, very severe silver syndrome. But typically, you would think about sapin, or which is basically very important gene, our protein. Has to do with the lipid trafficking. There are some, and the recessive forms of disease have some lipodystrophies, which are really not neurological, but lipodystrophies, but also provided very important clues about lipid metabolization and trafficking in HSPs. There's also a subtype called distal hereditary motor neuropathy type 5, when you basically would have some spasticity and distal weakness. Again, this is a hand of somebody with a silver syndrome with very flat thenar and hypothenar. We already seen this similar, so looking at some other types, so let me go through a few recessive conditions, again, kind of giving some sort of ideas about clues you can use for diagnosis. Again, it's very busy, pie chart, because, it's so much heterogeneous. Of course, you see big chunks of SPG4, SPG3, which are recessive, which are dominant. Again, recessive disorders would be about 25% of all of them. But then it's really, none of them are very common. So again, as I said, they tend to have a relatively early age of onset and complicated phenotype. Even though paraplegia, SPG7, which was one of the first genes reported, actually maybe 5% of all of them, so this is probably the most common. And actually, there's an interesting, debate whether paraplegia can cause also dominant disease. I don't personally believe that. But there's a few families describe, apparently dominant mode of transmission. But typically, these patients would also may have spastic attacks. If I have a few patients, or used to have a few patients in my care, who have basically spastic ataxia, so eye movement abnormalities, and they had a SPG7 mutation. So again, many times which is again mitochondrial gene, but it's a nuclear DNA. So it follows the autosomal inheritance. Again, here will be 25% risk of disease and 2/3 of being carrier. Carriers are normal, so you don't have any kind of manifesting carriers. Again, even though there is a few thoughts about maybe sometimes can cause dominant disease. So muscle biopsies can, we don't do them anymore, but defects in oxidative phosphorylation was found. So we would see typical regular fibers and abnormalities of cytochrome oxidase, that third C panel with cytochrome oxidase staining. So we would have basically fibers which are negative. So this is a typical mitochondrial dysfunction. Again, regular fibers, panel A and B. But so it's a mitochondrial disease. But again, it's a nuclear, so it's autosomal recessive condition. Imaging sometimes can help. So we talk about, I showed you imaging of spinal cord, which was almost completely gone. I mean, it was so atrophic, it is hardly ever left. But also the brain imaging can really give you some clues. And there are some of these patients have a basically thin corpus callosum. So spasticin, which is a common cause of relatively common SPG11. These patients may have intellectual disability, polyneuropathy, pseudobulbar signs, ataxia, again, amyotrophy. But again, they have a very thin corpus callosum, even though it can be also done in the SPG11, SPG15. And so again, but its MRI can give you a clue. I have a few patients with a thin corpus callosum. I said, like, this is SPG11, and I was correct, each and every time. But it's just it's really just statistics, because SPG11 is very common. But so show you the imaging. You have on panel A, you see very thin corpus callosum, but also look at the fornices here. We had a paper published about 2 years ago in a big corporation. So my SPG11 patients were included there. Looks like so this is European links. So if you look at so this is basically the inverted negative. You see its ears has this kind of and so if you look at this, sort of looks like on the MRI, this kind of looks, we call it ear, the links. So if you look at the sort of fornix of this, of the corpus callosum, it's a properly basal flare, which is, again, I'm not sure you see my mouse, but the lowest the lower upper quadrant of the slide. Again, I'm not sure you see my mouse. So this is called, ear of the lynx. And again, but looking at the corpus callosum, so it would be most likely SPG 11. Sometimes SPG 15, but again, you need to do genetic testing. But I have a few patients I really didn't test, and and later on was tested. It was at least spatacin, which is almost like mouthful, which was actually. So there's a clues you can give you. They are not 100% proof, but they are quite helpful. And again, can be also very complicated because there are other conditions. Some of them actually have, so some of this, so this is actually called SPG 35, which is fatty acid 2 hydroxylase mutations, and some of these patients may have a leukodystrophy, and some of these patients have signs of iron deposits, so it completely falls apart. And like, what is the disease? Is it HSP? Is it iron overload? Is it leukodystrophy? And all of the above is, so the answer would be all of the above. So if you look at the MRIs, you see nicely signs of iron overload, but also, quite significant leukodystrophy. So again, blood thickens. I think that, our classifications need to be really based on both clinical, but genetics helps. Of course, genetics helps. At this point, you can still argue that genetic diagnosis does not change the management, but yet, as I said before, it's obviously a matter of time. Hopefully in my professional lifetime, you will see some specific disorder treatments based on genetic mutation, and also gives you very important, prognosis, and of course you can, for counseling, recessive gene versus dominant gene gives you very different risk for the offspring, for instance. So those things are still very needed, and so genetic, so having even a clear-cut understanding is this de novo mutation of dominant disease versus a recessive disorder, and all these, young parents, young adults who want to be parents. So we did a lot of testing for really genetic counseling purposes. Troyer syndrome is very rare. You remember seeing my patient with a very flat hand, which is the silver, which is dominant. It's recessive. It actually was described in Ohio Amish. I was told by Dr. Davis, who grew up in that area. He's not Amish, but he grew up there. The Troyer is a very common surname, last name. And this disease was named after the family where the kids. But of course, this is clearly very typical inbred. So very typical scenario of high in consanguinity. They are so consanguineous, that. I'm not trying to be offensive, but their family tree looks like a wreath. But again, they have a short stature, mental retardation, intellectual disability, spastic dysarthria, and again, this is called Spartin. So it's almost like mouthful, with gene, and so this is it's very rare outside Amish population, but when I go, outside hospital, I'm not sure they're Mennonites. I see, or maybe Amish, who come to Norton Children's Hospital. So again, I can never tell them apart, Mennonites versus Amish. But also these patients are here, and again, they are from Ohio, so it's possible that some of these patients may be living, Indiana and come to you. And so if you see these patients, think about Troyer syndrome. Kind of finishing, again, so let me talk about only one type of X-linked, which I mean, this actually was the first one. It actually was on a long arm XQ28, and so basically this is also allelic, so same gene causing called Massa syndrome. Again, mental retardation, aphasia, shuffling gait, adducted thumb agenesis. So this is agenesis of extensor pollicis longus muscle, very specific. They also have something that's called crash syndrome. So basically, with a spinal cord. They would have corpus callosum hypoplegia and also hydrocephalus, and hydrocephalus is actually obstructive. It's actually stenosis of the aqueduct, so it's very, I've never seen a case in my life, but this is, very, this is actually Japanese paper, but, really mildly abnormal MRI. Well, so this is severely abnormal, developmental. So it's LCAN1 basically really plays a role in development, so can give you very abnormal development, as you can see. So this is a kind of sort of flavor again. So genetic testing is important. So in conclusions, again, you have to always exclude treatable causes. Think about especially apparently sporadic cases. But imaging, of course, is very important. The therapy remains symptomatic. Again, I didn't talk about cellular biology, which is fascinating, and that's actually could be another. I'm not trying to volunteer for another grand rounds, not at all. But again, but clinically, it's also a fascinating group of patients, and you can be so relatively thorough in the thorough examination. You can have some ideas about the phenotype and genotype. And again, we are probably on the dawn of first trials with the therapy, so really cannot wait. So we probably have a few more minutes if I have any questions. But again, thanks for your attention. I see my clinical space and my camera, so you may see these patients in my clinic sometimes. And again, as I said, it's a thoroughbred horse. Doesn't really work in Kentucky, as I said, but these patients are out there.
Well, we saw one together, Dr. Hedera, but what was your go-to for genetic testing? Would you do a whole exome right off the bat? If you were not yourself, if you were one of us.
Still do panel. I still do panel. I mean, panels are still valuable. And again, in Vita panel is really comprehensive. Again, in Vita, they describe themselves as a Walmart of genetic testing, and I kind of like that. I don't shop in Walmart, but I mean, this is so. Again, I think panels are still very valid a way to do it. And again, in Vita panel is like 50 plus genes, so it's very comprehensive. And so that's my Athena is very expensive. I haven't used Athena 10 years. But Vita and that panel is very good. So Chicago is also a very good panel. So panels are still useful to go, especially if you have good labs. It's very comprehensive, both recessive, and you can also choose the recessive dominant versus because again, think about as I said, if you have a apparently sporadic case, you still have to think about dominant disease as well.
In kids, right?
Yeah, actually, we saw case, and I see these cases, they're kind of start following me. So, my patients are moving from Vanderbilt here. So you will see these patients a lot, not a lot, but, they are out there, as I keep saying.
Peter, can you hear me? Yes.
Yes.
I caught you right when you're taking a gulp of coffee.
Sorry.
This is Martin Brown. Thanks for that great talk. I appreciate hearing ALS and PLS mentioned multiple times when you're covering this topic, because for me, the differentiation of PLS and HSP is I'm still not sure on some of my patients. And I'm sure that some of my ALS patients, if I did genetic testing on everyone, I might find one of these genes in one of them, even without a family history. I think that the genetic testing is, and this topic, this disease that we've lumped together as HSP, it teaches us that the genetics are not always it's great to have a gene that tells us what's going on, but the mutation, even a single mutation in a single gene in the same family, it can look different. And I think we're just sort of finding the limitations of these going after a single target. I mean, what's being developed now are these ultra precise treatments for, like with Duchenne muscular dystrophy, if you have an exon in 53 or 55 or 45, we can skip this one, and the idea is, well, now we've fixed it. But I don't think that I think we're gonna find that there are actually more genes playing a role in diseases. As we find more and more ultra precise treatments, we're going to find more and more that there's more than one gene causing the phenotype, and our job really is to manage the phenotype as far as like once the diagnosis is made. The phenotype is really what we're dealing with. The genotype is very important. It might tell us about the phenotype, but the phenotype is what we're going to have to be managing. So thank you for that talk. It was great.
Thank you. Absolutely, yes. And again, it's very humbling. I think that, sometimes the genetics were kind of arrogant, so this is HSP and this is great ataxia. Not so fast. And again, and so genotype was kind of really humbling that, there's overlap. And I agree that, of course, we have 30,000+ genes plus a lot of splicing. So this intrafamilial variability can be phenomenal. And so understanding that, of course, will take a lot of time. But I think it makes sense to, really phenotypic classification, again, prognosis. Of course, ALS is a very different prognosis, but even PLS, degree of, total spasticity, really pseudobulbar, problems, they are essentially sometimes mute, or they can really talk, So it does make a difference for the management of phenotype, as you said, which I really like that term. But I think that's kind of really a combination of they're not mutually exclusive. But again, it's kind of interesting the therapies, whether they will be genetically based versus having some sort of symptomatic. So these are exciting times in neurology. I guess it's time to go to clinic for everybody. So again, sorry, I don't want to cut anybody off. Unless there's any other question, again, thanks for your attention, and we'll see these patients in my clinic. If you come to the Fraser, you will see them. Thanks so much for attention. Take care.